Chapter 31, Pain, Comfort, and Sleep. Okay, so what is pain? Basically, pain is just a feeling of distress or discomfort. Okay, and remember in our previous chapter, we stated pain is considered um, our fifth vital sign. And so the Joint Commission requires that every uh, assessment that we do on patients, we also include a pain assessment. So when we're doing our vital signs, we should also be doing pain as a vital sign as well. And remember, pain is whatever the patient says it is. If the patient says their pain level is a 10, their pain level is a 10. If they say their pain level is a 0, then it's a 0. You can't look at the patient and say, oh, you're smiling or laughing too much. You're not in that much pain. It's whatever they say it is, and we can't uh, say otherwise because only the patient can tell us what their pain level is. And remember, when we're documenting pain, um, we need to do a full pain assessment. And remember our OPQRST, so onset. Onset meaning when did the pain start? So kind of assess that situation. What was the person doing when the pain started? Did they injure the area or, what was going on? So onset, how long have they had the pain? Provocation versus palliation would be our P. So provocation versus palliation. That means what makes the pain better, what makes the pain worse. Um, Q would be quality. Quality is the pain dull? Is it sharp? Is it burning? Is it aching? Is it throbbing? Is it stabbing or whatever? What's the quality of the pain? R stands for region or radiation. So region being where is the pain located? And radiation being does the pain radiate anywhere, right? So um, for instance, does the pain start in my chest and possibly radiate to my arm or whatnot? S would be severity, so that would be based on whatever pain scale you would use. The most common pain scale being a pain scale of 0 to 10, with 0 being no pain, 10 being the worst possible pain. We'll talk about some other possible pain scales as well. And when you're doing your documentation, you want to make sure you document what pain scale rating you use. And then T would be timing. Um, Timing also includes, when did it start, but also does it come and go as far as timing? Does it come and go? How long does the pain last or whatnot? So you want to make sure you include all those things in your pain assessment. So as I stated before, the Joint Commission requires that everyone receives a pain assessment. And so pretty much all of our patients will, have a pain assessment, but you might experience pain. I mean, you might expect pain to be in certain patients. For instance, your post-operative patients, patients with a fracture, patients with cancer, patients that had a MI, which is a myocardial infarction or heart attack, headaches, you know, uh, wounds, things like that. You would expect those patients to have pain. But whether your patient has those issues or not, you're going to do a pain assessment irregardless. Okay, so the gate control theory. The gate control theory says pain is controlled by a gate mechanisms. So basically what that says is, or what that means is, if that gate is open, then that allows the patient to experience pain. And if that gate is closed, then pain uh, can then be eliminated or blocked if that gate is closed. So, what types of things can possibly open that gate to allow the patient to experience pain? For instance, if I burned myself or I cut myself or something like that, or had some type of trauma, that could cause that gate to open, and then the patient would then experience pain. So, what kind of things can happen to close the gate and stop the pain? So, the gate can be closed by things like pain medications or massages or things like that. So, pain uh, control mechanisms or things that close that gate can be pharmacologic or non-pharmacologic, and we'll talk about some of those non-pharmacologic measures in a minute. Also, this theory says a lack of input allows the gate to open. So, in other words, if there's no input going into the brain, the person's bored or lonely or things like that, then they can experience more intense pain because there's no input or activity to the brain. Okay, so the body has some natural uh, pain uh, relievers. Um, endorphins. Endorphins are hormones that are in the brain that are considered natural painkillers, right? So the word endorphin comes from the word morphine. So when stressors occur, so going back to our scenario, getting burned or cut or something like that. So when some type of stressor occurs, like morphine, the endorphins will attach to the nerve endings in the brain and block the pain from occurring. So our body has some natural pain relieving mechanisms to also help uh, with pain as well. Okay, so we have different types of pain. Acute pain versus chronic pain. So, in acute pain, that usually has a rapid onset and a short duration. And so, it's associated with tissue injury or disease, and it usually resolves itself, and it could be with or without treatment when the healing occurs. Additionally, the acute pain is thought to serve as a protective role by alerting people that um, damage is taking action. And so, they need to take some type of action to try to prevent further damage from occurring. So that doesn't mean that the acute pain is not severe. Actually, the acute pain can be very severe and can actually interfere with the healing process. For example, if you have a person with pneumonia and they experience severe chest pain, then that person tends to limit his or her movement. And so they might refrain from coughing or keep coughing to a minimum. And we need them to cough to, get those secretions moving. And so this in turn might worsen the condition by allowing the secretions to continue to pool in the lungs. So it becomes important for you as the nurse or the healthcare team to intervene to minimize the pain. So you can teach the patient to cough with a splint or something like that, or administer pain medication so that they can continue to cough. Acute pain can also interfere with a person's ability to perform activities of daily living. And so, but fortunately, in most cases of the acute pain, the negative effects are short lived and the person can eventually return to a normal lifestyle. So, another example of acute pain, maybe I fractured my leg. And so, it occurred rapidly, but once that fracture heals, I'll be back to my normal self and able to function normally. And like I said, it might impact my activities of daily living, but once I get that healed, I'll be back to a normal lifestyle. On the other side, chronic pain. Chronic pain persists beyond the healing phase, usually 6 months or more, and so it doesn't serve as a protective function, and it's a source of just useless suffering to the point that the individual's overall quality of life is negatively impacted. And then cancer and arthritis are two conditions frequently associated with chronic pain. One of the most difficult characteristics of chronic pain is that sometimes it's not possible to determine what's causing the pain. And so in that case, it would be called idiopathic if you don't know what's causing the pain. The person's life might be turned upside down, and the individual might find him or herself not able to work, not able to socialize, can't perform basic activities of daily living. People who experience chronic pain become frustrated, agitated. They start feeling hopeless, might become depressed because they can't get out and socialize, they can't work, or things like that. They also sometimes they could be mislabeled as drug seekers because of their constant requests for pain medications, or their frequent changes from one doctor to another. And so, on the contrary, the person experiencing chronic pain who exhibits these behaviors may simply be trying to find some relief from the constant suffering or whatnot. So, we have some other types of pain as well: nociceptive pain, neuropathic pain, and phantom pain. Um, Nociceptive pain is pain that results from some type of injury or disease, and neuropathic pain is pain that results from actual nerve dysfunction. So, nociceptive pain is further broken down by specific origins. You could have somatic pain or visceral pain. So, somatic pain that's non-localized, and it's most often originates from tissues tissue damage, like a burn or something like that, muscles, tendons, ligaments, things like that. Um, Whereas visceral pain originates from various organs in the body. So they're both non-localized. It's just a matter of where it's coming from. Like I said, the visceral pain would be coming from an organ. Maybe I had a gallstone in my gallbladder. So then that would cause, pain from the gallbladder, which is an organ in the body. Neuropathic pain occurs because some type of damage to the actual nerves that are involved in the transmission of painful stimuli. So, neuropathic pain is also called nerve pain. A lot of times people describe it as a burning or tingling sensation. Burning or tingling sensation, that would you might see the word paresthesia also called that. Sometimes people compare it to like an electrical shock. So, for example, people with shingles might complain that the touch of the sheet against the affected area becomes severe pain, because it's the nerve damage. Diabetic patients, they tend to have this neuropathic pain. And then phantom pain occurs after the loss of a body part. So maybe I had my leg amputated, but then I'm still experiencing pain as if that leg is still there. It's phantom pain. The leg's not there, but I'm still experiencing pain as if the leg was there. And that pain is real. So don't tell the person that they're not experiencing pain because that extremity is not there. The pain is real to them and they still need some pain relieving measures. Okay, so like I said, with acute pain, that pain has a rapid onset with a short duration. So you get burned, you get a fracture, you get a strain or something like that, pneumonia, sickle cell crisis, herpes zoster, infections, those type of things will cause acute pain because they would have a rapid onset. But once the person is healed, then that pain will resolve. So anxiety or fear actually can cause uh, a person's pain to be worse. So you want to make sure you keep your patient relaxed. Keep calm, relaxing environment for them. The pain is usually relieved when the cause or whatever, like I said, is resolved. Also, with acute pain can cause your other vitals to increase, like your heart rate, your blood pressure, your respirations, things like that. But again, Pain is whatever the person says. So don't say because your heart rate's not elevated or your blood pressure's not elevated, you're not in pain. You can't look at those things and determine if a person is in pain or not. But those things tend to increase with pain. But don't look at that as your marker for whether they're in pain or not. Okay, and then we said chronic pain is pain that persists beyond the healing phase. So 6 months or more, it's a long period of time. It could be throughout a lifetime. Like we said, some uh, things causing chronic pain, people with cancer, people with arthritis. Also, chronic back pain can be an issue uh, for individuals. And so, with these individuals, sometimes you might need um, several diagnostic tests to identify the source, especially if it's like back pain or something like that. You might need different diagnostic tests to try to identify what's actually going on. They might require multiple pharmacologic and non-pharmacologic measures to try to their treat their pain. Over time, people with chronic pain, like we said, it can cause psychosocial effects on the person because they might not be able to work, they might not be able to participate in social activities, they might not even be able to perform things such as their activities of daily living and have to depend on other people because that pain is so severe. So keep that in mind as we're tending to and providing holistic care to these individuals. Okay, so nociceptive pain involves four phases: transduction, transmission, perception, and modulation. So in transduction, that begins with tissue damage causing the pain sensation. So I burn myself. I put my hand on the hot stove and then I burn myself. Right, that's transduction. Transmission is movement up of the pain up the spinal cord. So then a message goes up the spinal cord to my brain. Then perception. Perception is the pain impulse reaches the brain and pain is recognized. So perception, the brain perceives that pain occurs. Modulation, the neurons in the brain send a message back down the spinal cord. So the brain then sends a message back down to my hand, move your hand off of that hot stove. Send a message for the body to do something. So that's the four phases that nociceptive pain occurs: transduction, transmission, perception, and modulation. Okay, so controlling nociceptive pain, a lot of different things. Like I said, you might use pharmacologic or non-pharmacologic pain measures. Using different pharmacologic measures depending on what you're trying to do. What phase are we trying to block? Transduction, transmission, perception, or modulation will determine which type of pain medication might be most effective for your patient. So NSAIDs, those work at blocking transduction. So transduction, remember we said that's the point when you actually sense the pain. Um, and then opioids, those block the transmission piece of it. So transmission is it won't send the message up the spinal cord to the brain. Um, Guided imagery, that's a non-pharmacologic measure to block perception. Perception is when the brain actually perceives that that pain. And so you can do non-pharmacologic measures like guided imagery. We'll talk about some more about some of those non-pharmacologic um, measures as well. Okay, so like we said, neuropathic pain. Um, the pain receptors in the body are more sensitive, as with cancer patients, because the nerve system is not functioning appropriately. So that can occur in like your cancer patients, like I said, your HIV patients, your patients with Guillain-Barré, those individuals, the nerve, I told you before, diabetic patients can have neuropathy as well because the nervous system is not functioning appropriately. So when treating neuropathic pain, our traditional like opioids and things like that are not going to be effective. So these patients might use anticonvulsants, they might use antidepressants, corticosteroids, NSAIDs, things like that to help with their pain because your typical opioids are not going to be effective with people with neuropathic pain. So, like I said, your phantom pain that occurs with the loss of a body part, or so you had some type of amputation, and the person's still experiencing pain in that area where where the extremity was once located, and so that pain is real to that person. But again, your traditional methods might not be effective, for these individuals, and so sometimes a TENS unit um, might be helpful or a TENS unit that's implanted in the thalamus might be helpful for these individuals if they are not able to control um, or have that pain control by some of your other methods. So, as I previously stated, we have different types of pain scales that we could use. And so, all of your patients may not be able to use the same type of pain scale. If you have your normal healthy adult that's has their mental faculties about them, then that number scale ranging from 0 to 10, with 0 being no pain, 10 being the worst pain. Um, would be your more frequent type pain scale that you would use. Um, Children and some adults um, may not be able to use that numeric scale. And so we have the Juan Baker Faces scale. You can see a picture of that in your book, figure 31.5, the Juan Baker Faces, where you have the happy smiling face with no pain all the way up to the patient, the face that's crying and sad and whatnot, to the worst pain, and they can pick which face um, would be most identify with their pain level or whatnot. The NIP scale, the neonatal infant pain scale. Are they crying? Do they need oxygen? Are their vital signs increased for your neonatal patient? Cries, CRIES. Are they crying? Do they require oxygen? To maintain their saturation levels? Are their vital signs increased? What's their expression like? Are they sleepy? And then you have the PIP for the premature um, infants as well. You also have your scale for your confused patients, for patients that are confused. What's their how we're going to assess those individuals. Um, so you can assess, using are they um, nonverbal cues. So are they rocking and pacing? Are they restless? Are they rigid? Are they guarding an area or wincing or crying or grimacing or things like that could be indicators to us that they might be in pain. You have that FLAC scale, FLACC, faces, legs, activity, crying, consolability. So that's one that the nurse can use to assess their pain. And so the nurse would actually be um, rating the patient. What's their face like? What's their leg movements like? What's their activity like? Are they crying? Are they consolable? Things like that. So the nurse would be rating the patient using that scale. And so whatever pain scale you use when you're doing your documentation, you want to make sure you document which pain scale you use to assess your patient's pain level. Okay, so like I said before, you're going to have some non-pharmacological pain relieving mechanisms that a person can um, can use as well, because some of your pain you might have to use a mixture of pharmacologic or non-pharmacologic. Also, some people might be able to control their pain just by using non-pharmacological measures. And so here's some different type pharmacological, non-pharmacological measures that we might be able to use for our patient as well. The TENS machine, the transcutaneous electrical nerve stimulation. And so it uses electrodes with to provide electrical stimulation to try to block a person's pain. Or the percutaneous electrical nerve stimulation, and it's electric current that's sent through needle probes. And so a lot of times they'll use that for like low back pain or headaches or things like that. Binders. Binders, that's a cloth wrap that goes around a body part. You might have seen them for the abdomen, an abdominal binder. But they also have binders for the extremities as well. Those could be good for like a sprain, a strain, or some type of surgical incision or whatever. Heat and cold has been used as a non-pharmacological pain measure. Cold is used to decrease swelling, and so it does that by preventing blood flow for going to that area. Also, make sure you use a barrier if you're using ice packs. Use a barrier. It doesn't have to be something thick, just a barrier between the skin and the ice pack because you don't want to cause frostbite. And then that should be no more than 15 to 20-minute intervals. Um, Also, be careful when you're using heat because you don't want to burn your patient when you're using heat. And heat will help to bring blood flow to the area. So, and get that oxygen and nutrients to that area. Relaxation, that's another non-pharmacologic pain measure. Biofeedback. Biofeedback is when a machine is used to try to help the person to relax by controlling their heart rate so that they can control their heart rate, their respirations, their blood pressure. And so that way, uh, that can help to, they use electrodes. So the electrodes are placed on the person. And so then it trains them to, control those involuntary mechanisms. Distraction, that's when you focus on something other than the pain. Guided imagery, we talked about that already. And so you're verbally guiding them, the patient, to imagine something. Maybe it's their calm, happy place or whatever. So guided imagery. Meditation, we're focusing on a single stimuli to clear our minds and relax us. Music, massage, hypnosis. Hypnosis induces a trance-like state, and so that's been used for pain as well. So these are just some other, some non-pharmacologic measures that you can use for your patients as well. All right, so um, some pharmacologic agents. Um, Such as your aspirin, your Tylenol, your ibuprofen. Those can be purchased over the counter by the patient, but others require a physician's order. The responsibility for administering pain medications rests primarily with the nurse. So the nurse determines when to administer the medications, the effectiveness of the medications. Remember, I said you need to get a pain rating before you administer that medication, and again afterwards. Depending on the route, will determine how soon afterwards you'll get another pain medication to determine the effectiveness of that pain medication. You determine whether there is a need to notify the physician for any adjustments in the prescribed medications. Okay, pharmacologic options. Those can be include non-opioid analgesics, opioids such as your narcotics, um, or your other type analgesics. Remember, we said for the neuropathy pain, um, you might use antidepressants or anticonvulsants or corticosteroids or things like that for your neuropathy pain. So you can be using those for pain medications as well. When you're administering opioid medications, as the nurse, you need to monitor the patient for respiratory depression as well. Medications can be administered topically, orally, IM injections, so that's your intramuscular, intravenously, which is your IV. You can administer it via epidural or intrathecally. So those are some different ways you can administer the type of pain, the type of medication, the origin of the pain, the desired duration, the patient preference. Those are all some factors that are considered when determining the most appropriate medication route. A patient controlled analgesia or a PCA pump, right? So that is also used to significantly improve pain control because the patient can tailor the timing to his or her unique needs. And so you have to monitor the patient closely. Now, before a patient can use a PCA pump, it has to be determined that the patient is able to um, push the button, him or herself, because the patient's family is not allowed to push that button. The nurse is not allowed to push that button. So if the patient is not able to push that button, him or herself, then the PCA pump is not going to be the best measurement or pain method for them. Also, the patient has to be taught that they cannot overdose themselves while they're using the pain control analgesia pump because um, there's a lockout button. So whatever the doctor prescribes, maybe they say they can get 5 milligrams every 10 minutes. They can continue to push that button. They can keep pushing that button and pushing that button however many times they want to. However, only 5 milligrams every 10 minutes will be dispensed if that's what's ordered. So whatever's ordered is how it would be determined. Now the PCA pump, that can only be programmed by your registered nurse or your pharmacist. The pharmacist and the registered nurse are the individuals that can program that PCA pump. There are several different types of pain. Which type of pain occurs after the loss of a body part from an amputation? So the answer is for phantom pain. Phantom pain occurs after the loss of a body part from amputation. The patient may feel pain in the amputated part for years after the amputation has actually occurred. Okay, Kathy is working in a mother baby unit. Which pain scale is used to determine if the baby is in pain? So that answer is for NIPS. NIPS is the neonatal infant pain scale, and it's a scale used in the mother baby units. The FACES scale is often used in children who are unable to verbally communicate. And then the FLAC scale is the face, legs, activity, cry, and consolability. And it's used in non people that can't communicate well. Um, and then PIP scale is the premature infant pain profile scale, and it's used in the neonatal intensive care units only. Karen's patient is prescribed a COX2 inhibitor for her pain. Which of the following is an example of a COX2 inhibitor? So the answer is 3, anti-inflammatory. A COX2 inhibitor blocks the COX2 enzyme, and they're especially helpful in reducing arthritis pain. So the only such medication that's currently available is Celebrex. And these are the clinical objectives for the second part. Gather data regarding a patient's sleep difficulties, develop a plan designed to assist the patient in getting adequate sleep. So imagine being actively involved in some form of activity 24 hours a day, 7 days a week, and 365 days a year. Just the thought of this idea is tiring. So, therefore, if for no other reason, we need sleep to gain energy to be able to engage in activities without experiencing excessive tiredness. And by the same token, it's hard to imagine having to go through each day uh, of your life in some type of discomfort. Okay. Pain also helps with our general health, helps us maintain health. It helps us to recover from illness. And it also increases your ability to be able to tolerate pain. People that are not sleeping well will have can have increased levels of pain. Okay, so sleep occurs in cycles alternating with periods of wakefulness. So the sleep-wake cycle generally follows a circadian rhythm or your 24-hour day and night cycle. Most people are awake and busy during the day and sleep at night. Of course, there are exceptions to this rule, particularly for individuals who are employed in jobs that require working at night or rotating shifts. So, in addition to the sleep wake cycle, sleep itself actually occurs in stages that progress in a cyclic manner. So, there's 5 stages of sleep. So, stages 1 through 4 is referred to as your non-REM or non-rapid eye movement sleep. So, you might see NREM because that's non-rapid eye movement or non-REM sleep. And so that non-REM sleep ranges from a very light sleep, which is stage 1, to a very deep sleep in your stages 3 and 4. So in your non uh, REM sleep, the body is getting the most rest and the vital signs are decreasing. Um, during that state. So during your non rapid eye movement sleep, individuals usually experience a decrease in their temperature, their pulse, their blood pressure, their respirations, and their muscle tone. So the decreased demands on the body are thought to serve as a restorative role, both physiologically and psychologically, right? So stage 1, that's considered your transition. That's your light sleep. That lasts for about a few minutes. You're just drifting off into a light sleep. Stage 2, the person falls into a deeper sleep, lasts about 10 to 20 minutes or so. Stage 3 is considered your delta sleep or your slow wave sleep. And so that lasts about 20 to 40 minutes. During this stage, your respirations and your heart rate decreases. Your body becomes immobile during that stage. Stage 4, you're in an absolute deep sleep. That lasts about 30 minutes. The person is difficult to awake in this stage 4. You've ever had a person where you tried to wake them and they're just knocked out, can't move. They're difficult to awake um, during this stage 4. Okay. The REM sleep, which is the rapid eye movement. REM sleep is rapid eye movement, and that's when the person is dreaming. So there's high level of activity, and your vital signs are as if you are still awake because there's still a lot of activity going. So the REM stage of sleep is characterized by an increased level of activity compared to the non-REM stages. The benefits of the REM sleep seem to be related to an improvement in the mental processes and emotional health. So throughout the night, the body goes back and forth between REM and non-REM sleep, usually about 90-minute cycles. The person will go back and forth. Okay, so newborns, you can see, spend most of their time sleeping, approximately 16 hours in a 24-hour time period. Most of this time is spent in the REM stage. So in general, children progress through childhood. The number of hours spent as they progress through childhood, the number of hours they spend sleeping tends to decrease. Um, and the amount of time that's spent in the REM stage also decreases. The exception to this is when you have your adolescents and preteens who might require more sleep during a growth spurt. So if they're having a growth spurt, they might require more sleep. And then the quality of sleep during the childhood years might be influenced if they have different fears or nightmares, the child's activity level immediately before they go to bed, the amount of sleep and the intervals of sleep change as the adult ages. So you can kind of see here this chart that goes through newborns requiring at least 16 hours a day when they become get to age 1, about 12 to 14 hours, preschool 11 to 13, school age 10 to 11 hours, adolescents 9 to 10 hours of sleep at night, and then adults needing even less sleep at 8 hours of sleep a night. And so the adolescent's internal clock um, doesn't trigger feelings of sleepiness until the late night, due to they have a major shift in their circadian rhythm. And so that occurs at this period in the development. A lot of different things can impact a person's ability to sleep and how well they're sleeping at night. There's some psychosocial influences that can impact their ability to sleep. You know, what are their roles in relationships? People that are married sometimes have difficulty falling asleep without their partners. The death of a spouse may have the same impact. On the other side, a person's if the person's spouse has sleep problems, like they snore or has sleep apnea or something, that might interfere uh, with the partner's ability to sleep well. Parents with young, sick children, that might impact their ability to sleep, or just parents with young children, period. Um, Work patterns, the time of day a person works, as well as the stability of his or her work hours, that can impact or cause difficulty with a person's sleep. Daytime light and environmental noises also make it difficult. Stress or depression, any type of stress, whether the stress is from the job or the stress is from personal issues, that can cause issues with sleeping. If the person's depressed, that can cause issues with sleeping. What's their lifestyle like? Activity and exercise patterns. Although increased activity and exercise have an overall benefit, the timing is very important to promote optimal sleep. So, engaging in increased activity and exercise close to bedtime might interfere with a person's ability to fall asleep. So it's best to exercise early enough to allow the body to cool down and relax. What are your eating habits like? The amount of food and the types of food a person eat can affect the amount and quality of sleep that they get. Eating large amounts as well as eating high fat or spicy foods immediately before going to bed cause abdominal discomfort and indigestion. And so that might cause issues with the person falling asleep. Consuming foods or beverages with caffeine or alcohol, that can prevent a person from getting a restful night's sleep. On the other hand, if you go to bed hungry, that can interfere with your ability to sleep, right? Environmental conditions, the environmental temperatures, is it noisy? The amount of lighting that the person has can also cause difficulty sleeping. Health issues, health and medical issues, people that have acute illnesses, they might have difficulty sleeping. Do they have difficulty breathing? Is their temperature elevated? Do they have issues with itching? Do they have, um, uh, just different health issues that could impact or impact their ability to get a good rest at night? um, the change of environment or the individual's bedtime routines associated with, if they get hospitalized or things like that. Are they on certain medications that can cause issues with sleeping? So there's a lot of different things that can impact um, a person's ability to sleep, and you want to make sure you're assessing all these different um, issues, if the person is having difficulty sleeping. Okay. So, insomnia, this is a sleep disorder, one type of sleep disorder. And so that's difficulty falling asleep or staying asleep. And so it can be caused by a lot of different issues. Does the person have stress? Do they have jet lag? Are they excited? Do they have illnesses? Or do they have poor sleep habits? Are they like when we talk about poor sleep habits, are they drinking caffeine, or alcohol right before they go to bed? Are there any changes in their sleep arrangements? Do they have medical conditions? Do they have psychiatric conditions such as depression or things like that? So all of these different things um, can cause a person to have insomnia. All right, sleep apnea. So that's periods of apnea. So remember we said apnea is no breathing, not breathing. So periods of apnea lasting 10 or more seconds while a person is asleep. Um, some factors that can contribute to sleep apnea may be alcohol use, obesity, smoking, um, your sleeping position, maybe if you're sleeping on your back, if you've got soft tissue obstructions, you've got jaw deformities, things like that. People that are snore heavy, or if they have daytime sleepiness, those might be some common manifestations that accompany sleep apnea. So a person that sleeps heavy, that might be an indication that they might be actually having sleep apnea. And so the person, um, uh, a CPAP or BiPAP may be needed to try to maintain airflow to prevent them from having that apnea or the period of not breathing. The difference, the BiPAP um, has two pressure settings to allow the person to get more air in and out of the lungs, and the CPAP has one pressure setting. The CPAP is used for mild to moderate sleep apnea, and the BiPAP would be recommended for a person with more serious sleep apnea. Okay, so narcolepsy, that's sudden onset, recurrent, uncontrollable, brief episodes of sleep during normal wake hours. So with a person with narcolepsy, they have excessive sleepiness. Episodes usually last anywhere from 10 to 15 minutes. And so the frequency of the narcolepsy or when they just fall asleep is not related to how much sleep they get. They could get a full night's sleep and then still just fall asleep at any time, whenever, wherever. They have a rapid onset of the REM sleep. They might have sleep paralysis. They might have vivid dreams during the period. They might have sudden muscle weakness for these individuals. And so that's called the uh, cataplexy when they have that sudden muscle weakness for these individuals. So right now, there's not really a known cure for these individuals, and so they, they really have to be careful because they could be, doing anything and just all of a sudden just fall asleep. And so they would need to, seek medical advice for this. Karen's patient is experiencing sudden onset, recurrent, and uncontrollable brief episodes of sleep during hours of wakefulness. What condition does Karen's patient have? So the answer here is 3, narcolepsy. So narcolepsy is characterized by sudden onset, recurrent, and uncontrollable brief episodes of sleep during your typical wake hours. And so these begin at any time of the day and last for a few seconds to more than it could be 30 minutes or so, but average is maybe about 10 to 15 minutes. Um, so Karen's patient is going home with a prescription for a sleep aid. When teaching the patient about the medication, Karen should be sure to include. So your answer here is going to be number 2. Medications for sleep are for short-term relief. So medications for sleep are for short-term relief only after consulting with a physician. Alcohol should not be used with any medication um, that induces sleep. Over-the-counter medications for sleep will make you sleepy, and hypnotics are used for sleep as well.